For our next Research Nexus meeting on May 17th, 2017, we're going to be discussing Bayesian Comparative Effectiveness research. It's a methodology for comparing different treatments that have never been compared before in the same study. It's also known as mixed treatment comparisons. So this is a 10-minute or so introduction to the topic, and we'll discuss it more on Wednesday, May 17th. During my time at the University of Arizona, where I was studying tobacco and smoking cessation, the question came up, which treatment system works better to get people to quit smoking? Is it the physicians who really scare patients into quitting? Or is it a physician making a light recommendation? Is it a quit line? And quit lines are national now, contracted with states to offer support for quitting smoking? Or is it social support, where you get together with a group of other smokers who are trying to quit? There are definite implications about cost effectiveness here and physician reimbursement. First of all, what we had to do was discover what the outcome or the measurement would be for defining quitting. And this is true for any kind of study that we're going to look at and compare to other studies. Are the outcomes the same? Are the measurements the same? The quitting definition is no smoking for 1 year. And a salivary test for cotinine can be used to compare to the reported behavior if quitters are truly quitting. The next step was to find all the relevant literature on smoking cessation. The treatments that we discussed were social support, group support for quitters, a telephone quit line, and two kinds of physician-initiated quit advice. One was more of a scary scenario where you have to quit today or you're going to be dead in a year. The other is a lighter one, which is, we highly recommend you quit, Mr. Jones. So there are good meta-analyses out there that are weighted and show the different research and the outcomes in terms of odds ratios or effect sizes. The question is, can we compare each one of these systems of care to each other? In the research, they're usually compared to a placebo or a waiting list control group. Can they be compared to each other directly? In the smoking cessation studies, these are some made-up examples of the type of studies that might be out there. There is, for example, on the first row, one trial that compares no contact to physician intervention to group support. And if we drop down to the number 12, there are 12 trials that compare no contact to physician advice and so on. So in this kind of matrix, we can see that physicians and groups, different kinds of treatments, are all compared in a sense through the no contact or control condition. And this is the fundamental process for the mixed treatment comparisons methodology. Here's another example of comparing different treatments that have not been compared directly in any given study. Study number 1 compares spinal manipulation to a control group. Study number 2 compares athletic training to a control group. Let's say this is for back pain. And indirectly, we can compare spinal manipulative therapy to athletic training through a shared control group condition. The fundamental principle here is we're doing comparative effectiveness across different studies which have not compared these treatments before. The purpose would be to obviate or reduce the need for prospective research, perhaps ruling out weak treatments or rule in strong ones before we spend a lot of money on prospective research. identify the best, most promising research areas which make a best return on investment for our research investigation dollars, and abandon areas that are exhausted and equivocal. Some treatments may not have much promise, and we shouldn't be spending more money trying to see if they work. The process looks something like this graphically, where we combine similar control groups and compare to treatments. So the control group variance will grow to a degree when the different control groups are combined. And we have the physical intensive, physical minimum, social support, and quitline smoking cessation groups that we're showing here that are related indirectly through these control conditions. The limitations of this method are that it might be too conservative. We might be ruling out treatments that are effective. It might be too liberal. We might be accepting treatments that are not effective. But we'd like to strike a balance and rule out duds before we spend a lot more money and time on them. Another important example is, do alternative medicines succeed where medicine fails? Do they really do better on conditions such as the following: pain, depression, fatigue, allergies, asthma, and warts, all of which have some psychological or psychovalent component and natural history that is independent of treatment. But the question is, will alternative medicines actually succeed here and be a better option for patients? So if they're effective, that's one thing, but perhaps they're just surprising, as when we find out someone whose cancer has remitted when they're under alternative treatments, alternative medicine treatments. That can be interesting because it's surprising, but it still needs to be checked out. And this kind of Bayesian indirect comparisons method is one way to check these treatments out, compare medicine directly to, or indirectly to actually, alternative medicine. So what we have is another tool, and this is what we're going to discuss on Wednesday, another tool for better decision making and a guide for research investment. Where should we turn our attention to research in an era of reduced research resources? I look forward to seeing you Wednesday.